All right, Steven. So you ready?
Yeah, let's do it.
All right, let's do it, man. So I think today you're gonna teach me about immediate placement in the aesthetic zone. Is that right?
That's right.
Awesome. So basically, I know nothing about it. So can you walk me through it? You're free to share stuff here on the screen. Can you screen share?
Yeah, it says you've disabled my participant screen sharing, which hurts my feelings a little bit, but
I'm such an asshole. Here,
yeah.
I enabled it.
Okay, there we go. So let me just find the right slide. You seeing it?
Yes, 1 second. Oops. Okay. Yep, I'm seeing it.
Okay, cool. So, yeah, we're going to talk about immediate implant techniques, and there's a lot to talk about in this topic. I mean, this is like you could go learn over like a couple of days. But we'll talk about it in about half an hour and get you the high points and show a couple examples.
Mhm.
So to get you an idea of how we get started, there's a lot of different ways to actually accomplish this, not just the metrics and where you got to be on the bone and the gums and all that kind of stuff, but the actual surgical technique that a lot of people don't seem to talk about is like how you're holding the drill and whatnot, right? So this case that you see on the screen, we're actually going to talk about at the end of the material that's more like the how-to. But I'm excited to be here with you, man. You and I have known each other for a couple of years now, I think, right?
Yeah, yeah.
Been a while.
You were helping out with the original Facebook group for
That's
Implant
right.
Ninja.
I was the moderator. I got to see how many people were joining every day. It was wild to watch that just explode. Most of my notifications on Facebook back then was just people asking to join the group. Well, a little bit about myself for those who don't know me. Sorry, I don't have video today. We were trying to figure it out, and it's just through my phone, my MacBook, and my computer. We just apparently we don't have anywhere to get video. But my name's Steven Vorholt. I'm a board certified dental implantologist. I practice down in Scottsdale, Arizona. So I'm a diplomate of the American Board of Oral Implantology, which means I've been out at least 7 years. I did 800 hours of CE and passed my oral and written boards this past year. So excited about that to finally have some alphabet soup of my own. I'm also right now working full time for Implant Pathway down in Tempe, Arizona. I'm the implant director there, so I basically help coordinate all the courses. I pick the patients, I do the follow ups, coordinate the restorations, and I'm one of the lead instructors there as well. So I'm excited to kind of reach out to your audience and talk about a specific topic, which is cool. Usually, what I'm teaching is kind of A to Z beginner implant stuff.
Mhm.
So it's always fun to kind of drill down and talk about one specific thing. When you and I first met, this this you texted me this.
Oh, that's right.
You're such a nice guy. Now I know this wasn't sent just to me, Ivan, and that's all right. But I mean, you're giving me your phone number. I got that. That's sweet. I wasn't a big fan of what you were wearing in the video, so I sent you this video back.
Sorry, brother. That's right, man.
I know it's a fresh wound what happened last weekend, but I'm still a Buckeye fan for life. So I know you only went there for your advanced education, so it's all right. I still love you. Um, but what I'm actually most known for and most of I think this science is known before is my extreme contribution to the All Index Handbook 2.0, and I'm sure you remember this is 2019, I believe we were talking, and you're like, Steve, you're amazing. I need some content for my book. And so if you flip all the way to page 347, you'll see these pictures here. And you'll see this shout out, which is really nice. Hey, now I want to share a case done with end sequence by the man, the myth, the legend, Dr. Alan Aptekar. These pictures of the packaging were set up by Dr. Steve Vorholt. So you're welcome, guys. You can now see what end sequence looks like when it comes in the box. I met Alan last 2 weekends ago in Chicago. Awesome guy. But this is my claim to fame. And I actually told we have four AGD residents down at the nonprofit clinic I work at, and they're all familiar with your book. And I said, wait, you don't know that I'm in the book? So I said, flip to page 347. My name is shouted out there. So,
Has anybody approached you about it? Did anybody say, "Hey, I saw your name in there"?
well, yeah, my nickname is figure 880, 881. That's kind of what I go by just on the street. People say, hey, figure 880 guy.
No, listen.
So So happy to have been a part, known you for years and years now, and watch the growth of Implant Ninja and your company and some exciting stuff going on. But Yeah, I'm glad my photos could help out for that case. Alan must not put his stuff in chlorhexidine prior to the surgery, so at least you have this one. All right, so let's get into the real nuts and bolts today. Immediate implant techniques in the aesthetic zone. This is something I think, for a beginner implantologist, this is probably something you avoid for the first, until you got a couple under your belt and you're comfortable with your kit and surgery and soft tissue management and whatnot. But inevitably, if you ask a lot of people, hey, what was your first implant? It's like, oh yeah, 22-year-old woman comes in with broken number 10 to the gum line, and you have to, you decide to dive right in. So knowing the predictable ways to get good results in the aesthetic zone is going to make your life a lot easier, and it's going to open up the options for you and your patients. So the techniques I think are super important to talk about. Uh, let's review the surgical principles. So it's a little bit different than what you're looking at in the posterior. Um, the platform level is super important when it comes to where it is in terms of the CEJ, or the gingival margin of your future restoration. So like all implant dentistry, you have to have the end in mind when you start. If you don't know where your gingival margin should be or wants to be, you won't know where to put your implant. And one of the biggest issues you'll see is people placing your implant not deep enough, right? And I'm sure you've seen that plenty. And now we have an emergence profile problem because most of these implants are placed pretty lingual or very palatal. So we need running room to allow that to go from the implant platform and kind of do that reverse S curve to get to the facial gingival margin. Without enough depth, you end up with a really short, stumpy tooth with a 90-degree emergence, which is just a soft tissue nightmare. Um, 1 to 2 millimeters below the buccal plate, and that's assuming we're doing an immediate, which we're talking about today, and then 4 to 5 millimeters from the interproximal bone, so that peak of bone between the implant and the adjacent teeth, and the contact point of your crown. And Tarnow has proven to us that that will get you a papilla.
I'm a little
Anything
bit lost.
above, sorry?
I'm a little bit lost there. What's that? The 4 millimeters? What does that
Yeah,
stand for?
so the 4 millimeters is from the peak of bone, interproximal bone, to the contact point of your crown and your final restoration. And
Gotcha.
that is for papilla fill. And if you go past 5 millimeters, Tarnow has showed that it becomes a lot less predictable, and you can get those dreaded black triangles where you won't get the full papilla fill. So, being really mindful with your case selection, like if you have someone with this very thin gingiva, thin biotype, high scallop, these are the kind that are going to be really, really technique sensitive. You come in with a guy who's got flat teeth, flat papilla, and a big mustache and doesn't even show his teeth off. That might be the first one you want to attempt, and see how your technique fares. But ideally, Ivan, all of these numbers play ball together. Like I think a lot of people look at these numbers and they think, well, shoot, like which one's the most important, right? Or how do I know like which one to choose? But ideally, in an ideal situation, all of these numbers play nice. They all kind of work, right? So we're 4 millimeters below the CEJ, which is also 1 to 2 below the buccal plate, which is also for the contact point, right? So, in an ideal world, this is true. If they're in a non-ideal world, then you start talking about, okay, maybe we do grafting first if we don't have a buccal plate, right? Or maybe we don't want to be placing this implant like 7 millimeters deep to the margin just because that's where the plate is. So, set yourself up for success and find situations where all these numbers are possible.
Steven, can I just ask you about one? Oh, never mind. It looks like you're getting to it right there.
Yeah,
Actually, there's one more question I have. Buccal plate thickness, like distance from the implant diameter to the outside of the buccal plate. What distance are you looking for there?
yeah. In the immediate situation, ideally, you're going to have at least 2.5 millimeters, because that buccal plate is going to resorb. Don't let anyone tell you that implants keep bone around. I think that is something that I used to hear all the time, that implants were, you know, um, bone maintainers, and we know that not to be true. As a matter of fact, you're going to lose a thin buccal plate, which I think we'll talk about in the next slide. You're going to lose almost every time, and so you're grafting that gap almost as a time saver for the medullary bone to kind of rebuild and stick around. So the rule of thumb is if that gap is larger than 2 millimeters, you should graft. I say if you can fit graft, you should graft.
Okay.
Usually I'm using some sort of xenograft or cancellous, something smaller particulate to get down in there.
Mhm.
But buccal plate thickness is key. And if you have a really thin buccal plate, I mean, I'm sure you know a lot of people, you may be doing it yourself, some of that socket shield technique, where you're leaving the root remnant on the buccal. so that PDL and that blood supply stick around and keep even a thin buckle plate in place. Because some of these cases where the buckle plate is paper thin or less than a millimeter, that's the most predictable way to keep that contour.
How thick do we want our buckle plate to be? In this case, like right, that little shell right there, how
Uh-huh.
ideal, perfect world.
Perfect world, 1.5 or larger, as far
One-
as the thickness of the actual plate. When you're placing your implant, you need to make sure your implant is at least 2 millimeters away from that plate. So, like in this graphic, this shows that we're probably a good 3-4 millimeters from the plate. The plate is pretty thin. So we are going to graft that. Soft tissue grafting at the time of placement is also a fantastic adjunct if you're not doing socket shield.
Mhm.
Because I think on your Instagram post today, we were talking about a buckle roll technique. Someone was asking about the buckle plate maintenance, and thick tissue is one of the best ways to maintain bone because it's all about blood supply. That's what it's all, the whole game comes down to blood supply. So if you can, and we'll have one example with and without, if you can do a flapless surgery to avoid removing the blood supply from that buckle plate, all the better. So really the ideal anterior immediate implant is a flapless surgery done all through just the socket of the extraction site.
Got it.
Yeah. So, but things like socket shield and root banking, these are further more and more advanced things past this. So if you can get comfortable with finding patients who have a thick buccal plate, who have a gap that you can graft for your first couple, just to get used to the surgical principles. But you have to maintain that buccal plate. When I was in dental school, the way to pull teeth was just to lean buckle. I don't know if that's what they taught you when you were in dental school, but easiest way to get a tooth out is to push it to the buckle because the buckle will always give. And nowadays, that's kind of the most sacred bone. If you're an implantologist, you do not want anything to do harm to the buccal plate. So it has to come down to atraumatic extractions first. For the most part in this graphic, we're looking at that little green circle that I've highlighted. That's the bone that we're going to utilize for our immediate stability. So when you have a socket, we need to engage bone that's apical and palatal to it. So hopefully your patient has bone apical and palatal to it. Ideally, more than 5 millimeters is great. Minimum 3 to 4 for the most part. What we want to avoid, Ivan, is having to use such large implants up here just to get stability from the socket walls themselves, that we now have very thin plates, like you mentioned earlier, and poor blood supply. So I think my ideal size for an immediate central incisor is probably like a 4.2. I think
Mhm.
you go above that, you're starting to give away to the biology of the mouth. Like I'd rather have an extra 0.4 or 1 millimeters of bone graft and blood supply than to have a 5 millimeter implant, which used to be the way that we did things. We used to put the largest implant you could fit, regardless. So I think a lot of people are really leaning towards that 4 millimeter zone. Canines maybe got to go a bit larger, just for the longevity of the implant. But yeah, for central 4.2 is kind of what I'm placing. That's what I'm grabbing if
Mhm.
I need to. You can engage the floor of the nose. If you really want stability, you can kind of just bite that cortical plate. It's a very thick cortical plate on most patients. And if you can't get stability, I'm not a really big fan. I don't know how you feel about burying immediate implants. I think it's a soft tissue um, potential problem because now you don't know how the soft tissue is going to heal every time. So if you can't get a healing abutment, I kind of lean nowadays towards just delaying the surgery and grafting. Certainly, if you're very comfortable doing some significant soft tissue grafting, like a pedicle flap or something like that, where you can get closure with extra soft tissue, by all means. But if we're talking about beginners, people starting this, rule of thumb is if you go through the drill sequence, you put it in, you're going 5-10 newtons. You're better off just taking the implant out and just doing a socket preservation at that point and coming back.
Okay, wait. So that's really interesting. So I'm placing the implant for an immediate, and it's going in really, it's really lame primary stability, really
Uh-huh.
low, 5 Newton centimeters. So what you're suggesting is taking it out, grafting, and closing it up, coming back to it.
Correct. I find that, let's say, okay, you put a cover screw on it and bone graft around it. Now, what's your closure technique? Because this is a flapless surgery to this point, right? So, are we now going to lay a flap and try to get primary closure by releasing the vestibule? Well, now we're going to have to do a second soft tissue surgery down the road to put that vestibule back. Are we going to do a PTFE cytoplasm membrane? Well, now we're really hoping that everything heals right where it's at because our implant is already in there.
Mhm.
So now we're kind of we're letting go of control of putting that implant at the perfect depth. Whereas you're better off just do the PTFE membrane or a pedicled CT graft from the palate and just let everything cook for a bit. We can come back, we can rebuild papilla, we can rebuild some soft tissue contour, but we can't replace the implant once it's been placed. So that's kind of been my go-to for immediate implants in general in the last 2 years. If I can't get good enough stability to put a healing above it, I really don't. I would rather just graft. And so if I'm doing a molar or a premolar, same thing. I don't want the body to have to jump, 5 to 10 millimeters over my titanium screw, which is something that tissue does not want to grow over. So I would rather, it's like healing abutment or bust for me, Ivan. And
Okay.
you let your patients know before the surgery starts. The last thing you want to do is ever guarantee a result, under promise, over deliver. So let them know, hey, we're going to get this tooth out. We're going to see if the bone's stable enough to get the implant in. If so, great. If not, I'll let you know, and we're going to do a great procedure to rebuild that contour and come back. So you just don't want to get yourself. And I've been burned enough, and maybe that's why I could say this stuff now. Trying to do. Let me throw a bunch of stuff in there and see if it heals with my implant. And save the patient 4 months, and sometimes it ends up actually taking them a lot longer because now we're talking about either replacing the implant or soft tissue grafting, all this kind of stuff at the end. So if you want, like, you're just starting, Ivan, because I know you're brand new at this. If you can't get stability, man, just bail. Just come back, do your socket preservation that you're very good at, very comfortable with, and come back to a healed site that you can then place the implant where it needs to be.
I like that. I really like that philosophy. If you're feeling unsure about it, just bail, because it's going to save you at the end of the day versus just like sinking it and then out of sight, out of mind, and then it's going to come back to you.
Exactly, exactly. And it looks like Sean in the comments was asking about longer implants than thicker implants in the interior for versus posteriors. And yeah, I think the biggest thing is initial stability, and the thicker you go, just the less blood supply. You have more bone contact, which you might want in the posterior, but for these anteriors, these teeth aren't that big. I mean, you don't need to be putting 5 millimeter implant. I've seen some with 6 millimeter implants in there. I was like, oh man. So yeah, I think 4.2, and I've even had 3.8 with pretty good success. So you've probably maybe seen this study from Howie Gluckman. He's down in South Africa. He's kind of the PET godfather, and that's the socket shield technique. But he had this study. It was just a CBCT review of hundreds of patients, or looks like 591 teeth, where they looked at the contour of the buccal plate. So to your point about how thick is the buccal plate, well, most class 2, which is B and C in this example, have very, very thin buccal plates. 83% in his study had less than a millimeter thickness. So if you think you can do this by leaning buccal to get this tooth out, you're absolutely incorrect. That buccal plate has to be maintained, and that's all about rotation. So you want to talk about extract. So I'm pulling for sex. It feels like a lifetime, but you have to get these teeth out without causing damage to the buccal plate. So I joke that I don't pull multi-rooted teeth anymore because I just section everything first, and I want to pull single roots by rotation only. So you're going to see most of class 2, A and B, like how he has it here with that thin buccal plate. If you're living well, Ivan, and God's smiling on you, you'll see class 1 more often than not. It's unfortunately pretty rare. He has it at 6%, but class 1 is one of the few sockets where you could actually just use the socket itself as kind of the angulation you need. You can see class 1 on the top left. There's a thick buccal plate. The tooth is in the middle, alveolus. Fantastic. If you see that in an X-ray, that's your ideal first immediate anterior implant. But most of us are going to be seeing class 2s, which means the tooth is a little bit inclined towards the palate, and we're going to have to do some correction to bite that palatal bone. We're going to talk about that technique here next. Class 3, 4, and 5, those are the kind you probably just want to know before you even go into it. This is going to be a grafting situation.
Okay.
And class 5 is extremely rare, thankfully, because that's a bad situation to be in.
All right. So I guess they're like in level of difficulty too, right? Class
In a way, yeah. In a
three,
way, I'm not sure if that's how he meant to do it, but yeah.
in class 2, we basically engage the palatal bone by angling a little bit.
Yeah, we're going to talk about that in great detail here next, because that's really the trickiest part of this. The trickiest part is, how do I get my implant to engage this palatal bone without getting A, deflected, or B, like not in the right spot, right? So there's 4 ways to approach this. So this is the part where it's like, okay, we're actually getting into the heart of the matter. We talked about the principles and what the goals are, right? So like where the numbers are, the millimeters and all that whatnot. There's four ways and generally to put an implant in the anterior for an immediate. You can either follow the trajectory of the residual root, so you can just go right up the root. Class 1 sockets, great, if you're living well. Number 2, you can just bisect the alveolus. You just put it right down the middle, okay? And there's techniques to get that done. 3, you can do a palatal placement for a cement retained crown. So we're going to be coming out the middle of the incisal edge, or maybe just facial incisal edge. That's going to be our angular implant. And then type 4 is palatal placement with screw retained crown, so the access hole is coming out the cingulum. These, kind of angle difficulty, kind of like the last slide, like top to bottom, it gets more difficult as you do 4 and 3 and 2. Okay. You can combine 3 and 4 nowadays. There's so many great restorative options for these angled screw channels that we have some better options. You don't have to nail everything perfect in the front. So this is option 1, which is, let's just follow the socket. Okay. The problem with option 1 is more
Steve,
often than not.
Did you change the slide, or are you still on this slide that says surgical approach?
Yeah, I changed the slide, but you should see a red implant over the socket. Got it?
Yep.
So this is option 1, where you just follow the socket. And in the class socket, great, right? This is the one we talked about that's right in the middle of the alveolus, and you're lucky you have that patient in your practice. If in most class 2 sockets, if you do that, you're going to perforate the buccal plate. The cribriform plate, which is that tiny cortical lining of a socket, is going to you start your drill palatal most aspect of the apex. As you go in and drill, you're going to have like that density of bone is going to push your drill buckle, because all drills want to go into path least resistance, right? So path least resistance at this point is the cancellous bone that's to the buckle, not the cortical cribriform plate. So what ends up happening, and we'll have an example of this, is this example here with the red implant kind of strip perfing apical to the buccal place. This isn't intentional, but it happens. Here's an example. Everything from in the mouth looks great, super palatal, right? But the apex of that implant, sorry if if you can hear the leaf blowers outside, the apex of that implant is just perforating or maybe engaging that buccal plate. One way you'll know that this happens, Ivan, since you're probably doing this flapless, unlike this example, is you'll get this insane amount of torque right at the end of your placement. And you're not trying to engage the nasal floor. So if we're trying to engage the nasal floor, that's what you expect. If you think that you're just in the cancellous bone apical to your socket, in the last couple turns, you're like, wow, really getting a good bite here, this is maybe what's happening. Okay. And the only way to really know is to have post-op CT or to flap and take a look, because the PA is not going to show you anything. What do you do in a situation like this? Honestly, I would just leave it. You've got good bone thickness on the coronal aspect of the implant. We're engaging the buccal plate very, very far up in the vestibule. We haven't flapped anything, ideally, so we haven't reduced the blood supply up there. If you feel it with your finger and it's sticking out, Ivan, you got to take it out. But this CT is probably lying to us just a little bit due to beam hardening, which means we lose a little bit of the visibility around metal artifacts. This is probably still in bone, just engaging that plate. And this will restore fine. It's not ideal, but it will be okay long-term because of the gap we have from the actual implant body to the buccal plate in the coronal aspect. Option 2, just bisecting the alveolus entirely. Great. This no longer has a problem with the buccal plate perforations, but look at our restoration axis now. So in a class 2 socket, if we do this attempt, we're suddenly coming out the mid-facial or maybe worse of our future crown. And now we're talking about custom abutments, right? Now we're talking about angle screw channels and maybe still a custom abutment. This can get difficult. And we know the loads in the anterior are already off axis as is. So now we've just made them a little bit more off axis, which isn't great. So here's an example of that. And this is an implant that I placed, like my second year placing implants. This implant was placed way too angled. You can see that on the post-op CT, I have 33 degrees to kind of like the occlusal plane. And we had to do, not only is that an angled screw channel on a custom abutment, then we had to cement crown over the top. So not ideal. This case had its own other complexities, but it can make for very difficult restorative plans, which is the whole idea of implants. And the reason I think it's a great GP like subspecialty is because we are thinking about the end first. We're thinking about where's the tooth got to go, right? We're not oral surgeons who are just looking for bone. we're looking for teeth first and then deciding what that means as far as the surgery. So this was, it restored okay. It was kind of a nightmare. I'm pretty sure if you do a case like this, you lose not only sleep, but probably money on a case like this, because by the time you get through all these custom abutments and try-ins and stuff, uh, yeah, you're not in all the chair time. It's just not something that's profitable. So doing it right the first time. The real bummer about this case is look how much bone there is in the palate of that implant. I mean, it was just operator error. So yeah, I'm not nervous to show my complications. If you know anything about me, I actually teach a 3-day course on implant complications, and a lot of them, are provided by yours truly. So I think if you're one of those people who say I never have complications, you're probably not doing that many implants, is my guess. But knowing how to treat them is more important than anything else. Now we're getting into the green implants.
Steve, I was just going to say, in those cases, yeah, you do lose money, you lose sleep, and also just having things that are not systematic in your practice, like having a quote unquote special case, just like throws everybody off. I like to basically just do all the cases pretty similar, so all the assistants know what's up and nobody's lost.
I 100% agree with you. The last thing you want to do is have a patient on the schedule and everyone in the office gets stressed that day because they see them coming in at 3 o'clock. Oh man, it's that case, and everyone has them. Everyone has either patients that are like that or cases that are like that are just maybe going a little sideways. They're trying to manage it, and it's a stress no one needs. And yeah, I avoid it like the plague now, but you got to know how to fix it if it happens. And you got to know what happened, right? If you don't understand what led to that, how will you ever avoid it again? So number 3, this is we're going in a palatal placement, so we're engaging the palatal bone, apical bone. We're not coming near the buccal plate, but we are turning our restoration axis now down the long axis of the tooth. So this generally will require a cement retained crown still, and a lot of dentists and implantologists kind of prefer a cement retained option in the anterior for aesthetics because they can get a little bit better ceramic sometimes from matching and whatnot. But this is a case where you're going to need a custom abutment and a cementable crown because your access hole will be right through the incisal edge, maybe a little facial. However, we talked about this earlier, but with angle screw channels nowadays, you can actually place like this and still have screw retained crown if that's kind of your goal. And my goal personally is to always have screw retained crowns. I like the bone maintenance around them. I like the lack of cement. I've seen way too many implants with periimplantitis due to cement, and the retrievability and just the simplicity of restoration. So I have no problem with this placement. If you go with an angled screw channel, you can certainly cement it. You just have to it's a whole different technique. Be very, very careful how you are cementing these crowns. So that's something like this. You can get a really nice custom abutment. The problem I've had with doing a cementable implant restoration is in the posterior, you can have your margin super gingival, where you can actually see it, clean it, keep it, get the excess cement out. We can't do that in the anterior. We have to bury that margin, half millimeter sub gingival, and now we're attempting to clean up cement we can't see. And we all know from our histology of implants, the connective tissue around an implant is not like a PDL. It's not attached directly to the cementum kind of thing. I likened it to a turtleneck. You have a tightening band of tissue around your implant head and your platform, but cement can migrate down that tissue. There's nothing if you took a probe, you can get that probe to the bone if you push hard enough, unlike a tooth. I guess you could do that in a tooth too if you really don't like your patients, but implants are a little bit different in that respect. So Thomas Levinskas had a great book, Zero Bone Loss Concepts, that talked about cement cleanup and how to do it if you have to do it, but the dangers of it. So this is still not my ideal, but totally reasonable, totally something that no one would blame you for if you did it this way. My favorite, but the most technique sensitive, is this kind of placement, which is we're engaging the palatal bone, palatal slope of the cribriform plate, and we're having a screw retained crown because we're coming out the cementum. The one downfall to this, Ivan, is if you do place this and you place it a little too.
Let me just ask you a quick question. Because you referred to it. Can you show us where is the cribriform plate? You just use your mouse cursor.
Can you see my cursor?
Yep, I can see it.
Okay, cribriform plate. Let me go back to the original here. It's this lining, this dense lining of your socket. Okay, when you pull a tooth and you take a curette in there and there's a hard bony wall that you're scraping off of, that's the cribriform plate. You can perforate through that into this.
You're talking about side, right? On the lingual side?
Yeah,
Okay.
that's the cribriform plate I'm more concerned about in this case, but there is one around the whole socket.
Okay.
So the hardest part, if you look at this, like in your what you're talking about, this implant like goes right through the cribriform plate, but that is denser than you think. So the hardest part and the technique we're going to talk about next, how do we avoid that slightly denser plate from deflecting our drills? Because this is mostly a blind technique, right? We're doing this flapless. We're doing this down a dark hole. That's like dentistry in a nutshell, right? So how do we keep that density from deflecting our drills, like that happened in the option A example, and pushing our apex buckle? So this is, I think, the most ideal. But if you place it too palatal, you can actually get what I would call like a bulky cingulum. And you look at the patient from the occlusal, and you can tell which one's the implant because the ceramic has to be so thick, right, for just restorative strength that you can get these really, really bulky cingulums. So it's very technique sensitive. If you go just a little bit too palatal, you get a tooth and you put it in the patient's mouth. They're licking it and they're going, like that feels really, really big. And you just have to be like, oh, you'll get used to it. You'll get used to it. It's not great. So it's that's one downfall to this technique, and it's very technique sensitive. So here's an example of that. We'll talk about this case in more detail at the end of these slides as well. But coming right out the cingulum, and you can see this cingulum is perfectly reasonable sized. So we're not going to have any of that problems.
Hey, Steven, just for
Yeah.
those who aren't familiar with what you got there, is that like a jig just to get it aligned properly? What's that thing
Yeah.
on top?
Yeah, we're
Just
going to
like,
go through this in great detail, but that's exactly what that is, Ivan. That's a jig that we use to seat that crown.
okay.
To get it in the right alignment. Yeah, and you'll see some more photos that'll kind of make that a little bit more clear. But long story short, patient came in with that crown broken at the gum line, placed it back finger tight because it did kind of line up, and then made this little jig so that I could put it back afterwards and pick it up.
Mm-hmm.
So that's the patient's original crown on that tooth. All right, so the techniques. The most important part of immediate implants is one thing, and it has to be atraumatic extractions. Must, must, must. If you lose the buccal plate, you're grafting. Just forget it. If there's a small dehiscence or fenestration, that's something maybe you can deal with. But if you lose the buccal plate, forget about it. We have to pull that tooth down, straight out, no buccal plate damage. And like I said, it's all about rotation for me. I don't do very much elevating either, just light elevation to kind of get the PDL starting to move, get the blood supply to get in between the ligament and the tooth. And then I'm a big fan of the Ash forceps because I feel like I have better handle with them. I think they're meant typically for like lower premolars. I use that thing everywhere except molars in the mouth, and I'm just rotating. So I will rotate till I feel resistance and hold it 15 seconds. Hold. Like have someone count because you will do 2 seconds and think you did a minute, and then rotate the other way. And then just a very, very light, almost like a figure eight, and that'll come out. You'd be amazed. You do this on your next tooth that you're pulling, you'll be like, wow, I didn't realize pulling teeth could be so. And the patient's like, oh, you're done? Like they barely feel anything. But that's how my technique to get these teeth out, especially conical roots, without any buccal plate pressure or potential breakage. So now we're talking about techniques, okay? When we have a technique to do this, tooth's out. We kept the buccal plate, fantastic, okay? There's 3 main techniques in my opinion. I'm sure there's more than this, but these are the 3 that I've used. You can use a Lindemann burr, which a Lindemann burr is that one on the left. It's a side cutting burr. It's used usually to correct osteotomies. So like your initial 2O goes in, you're like, ooh, my angle's a little bit not perfect. You take this, generally it's also 2 millimeters in width, and you can side cut or kind of re-angulate your initial osteotomy. You can even drag your osteotomy if it's too far in one direction. That's the Lindemann burr. So that's actually my preferred technique now for these that we're going to talk about. You can also do a freehand pilot drill. This is very technique sensitive. I have some friends who are excellent surgeons who utilize this technique, and they just nail it every time. And watching them is just like, oh, it's kind of brilliant. So you'll see that in a couple slides. And then guided, if you're a big guided person, I was huge on guides, like from years 1.5 to like 5 of my implantology journey. I did like 99% guides, like just that, hence the picture in your book, right, of the NDX in sequence setup. I've kind of waxed and waned on that quite a bit. I go back and forth between all guides, no guides, some guides. I'm kind of the opinion now that anterior immediate guides are probably not great. I think guides are good for a lot of things. I think we'll talk about why I don't think this is so good. I think it's actually more technique sensitive to do a guided immediate anterior than it is to do these other two techniques.
Hey, Steven,
Yeah,
I get the question all the time. Um, should you use guides? Should you not use guides? What's your take on it?
if I was in private practice, Ivan, I would.
It,
Oh, I lost you
I
there
was
for a
just gonna
sec.
say, just for the bread and butter. Uh, oh, sorry. Just for the bread and butter general dentist who's placing, I don't know, 10 implants a month.
Hmm.
Should all cases be guided or no?
Yeah, well, I would argue if a GP is placing 10 implants a month, he's not bread and butter, but that's that's really generous of you. That's a lot of implants. I think it should be guided. I think just makes everything predictable. Like you said earlier, it's all about systems and predictability. And if that just takes one more thing out of your hands that could go awry, I have a whole like 2 hour lecture on guided complications. It's not a panacea. It is not something you can just blindly use, close your eyes and go. One of my problems in my career was that 3.5 years where I did predominantly only guided. You started to lose a little bit of the tactile feel. You started to lose a little bit of the flexibility that when things don't go perfect or the guide doesn't fit or who knows, like there's so many things that can kind of go sideways. If you don't have the ability to go freehand, I think that's a disservice to your patient. I think you have to be able to go to the backup. You have to know the actual technique. I really don't like when people say like you should start guided and stay guided because I think that's a dangerous thing because it's going to be that one patient that nothing can go right on, and if you stick to the guide, you can get in real big trouble. Um, what I tell my new doctors who I'm training, Ivan, is I say, listen, like get pilot guides because the hardest part for a new dentist is to get that initial angulation right, to get that initial spacing right for their final restoration. But I want them to learn, at least for the first like 100 implants, the feel of the drill, right? So like do a pilot guide, get that hole perfectly where it needs to be, and then go to the 2.5, the 3.2, the 3.7, whatever setup you have, and feel what that feels like. Most of those drills are going to funnel into your pilot because that's just, like I said, path least resistance, right? But you're getting the sensation and the tactile feel as well. So you're getting kind of the best of both worlds. If after 100 implants you decide, man, I want to go fully guided and be placing stuff through the guide too, awesome. If you decide to keep the pilot, great. But if that patient comes in, my wedding's tomorrow, I got number 10 broke, like, are you going to be like, sorry, I got to make a guide. It'll take me 2 weeks. Now, when I was doing guides, I could do it in like 4 hours because I had a 3D printer and everything else. So I actually would kind of make a guide there. But yeah, like you have to be flexible in that. And we could get into you and I could have a long discussion about all on X and guided principles and that. And I have a lot of opinions on that. And that's come a long way since you and I first met. But I think guides cannot be a crutch. I think the biggest thing is that people use them as a crutch and they are just an adjunct. They're a surgical accessory, and that's it. So you can certainly use them very well. I know some people who use them way too often and have no really clear idea of what they're actually doing, which is kind of scary. But yeah, sorry, that's my soapbox about guided surgery.
It's all right. Just want to give my 2 cents really quick. I totally agree with you that you should be trained freehand first, so that because you can always have a bailout basically, and freehand skill set is king. I think, but I think guides to add efficiency to the practice makes sense if you're doing enough implants, or like pilot drill guides, like you said. I really like those because you're not leaning on them 100% because they're not going to be accurate 100% of the time for whatever reason. But
Yeah.
awesome. Here, I'll let you get back to what you were talking about, man. Sorry, I derailed you.
No, yeah, no, we could, and I'll talk to you all day about this stuff. I love this stuff. This is like all I do is talk and teach and learn about implants. So, um, but yeah, I think there's nothing wrong. Like if you're in private practice, there's nothing wrong if you have a system where you have an intraoral scanner, and maybe you have a 3D printer, maybe you have a lab. Like if you just do everything guided and your team knows it, you know it, great. You just have to not be completely reliant on it. That's it. So yeah, I mean, if I was in private practice, I would do everything guided, no question. But I also know how to handle it if it goes wrong. That's all I'm saying. All right. So so guided osteotomy, it has its pitfalls. So take a look. I made slides that move for you guys. Look at this. This is the Lindemann technique. I'm going to go back and replay this in a second, but the Lindemann burr is side cutting, and this is what in my opinion, in my hands, and that's true with all dentistry, right? Whatever works in your hands. this is my most predictable way to perforate that cribriform plate. We talked about the palatal slope of the socket is to go in there, angle it the way I want it to be, and then drag this kind of up that wall and create a slot, if you will. Okay, so that slot is now roughly 2 millimeters in width. I can go back now with all my future drills, my 2.0, 2.5s, and so on, and use that slot. Okay, let's replay that one more time. See if I can get this. Here we go. So I'm just going sideways, and then I'm going to go whoop, and just go up a little bit. It's side cutting burr, but it can go apical. Okay.
Steve, do you have to make that that sound effect while you're doing it? So while you're doing
I don't know. It works best for me when I go like this, and then 100%, 100%. Make sure you have a long enough Lindemann burr for this. You probably need a drill extender for a lot of these too. So if that's not in your kit already, you're going to want a drill extender that allows you to use a latch drill that's longer, or I'm sure you can actually buy Lindemans that are quite a bit longer. So because you're going to be doing this, like I said, mostly a blind technique. You're down deep in the socket, which is probably, I don't know, 18 millimeters. And you can't have your drill bumping into the adjacent teeth. So you're going to need something to extend that. Option two is what I think is very technique sensitive, but works great in some people's hands, is to go in at an extremely acute angle to that plate. Actually, more coronal than my thing shows here. I'd actually probably be biting like well up here, like 2/3 to 3/4 of the palatal plate. And then you're going to, as you perforate, you're going to re-angle and continue drilling deeper. So perforating, re-angling your drill to where you want ideal, and then going. Okay. You can see why this is be a little bit more technique sensitive, right? And every drill has to do this. So the next drill in the sequence, the next drill in the sequence. Now, I say every drill, you're probably only using 2 drills here. Like this is an immediate implant you want stability in, right? So you're probably not going past your 2.5, maybe the next one to put your 4, 4.2, or 4.5, whatever it is. So it's not like we need to go through a whole sequence, but we'll do that one more time. And like I said, I would most likely be doing this a little bit more up high, more coronal on the palatal slope. So you're going to perforate, turn, this drill's still spinning this whole time, and then you're going to go deeper, more apical. Okay.
That's actually my favorite way to do it.
That's your way to do it? Okay, cool. So yeah, so you and I do it a little bit differently. I think the biggest mistake people make, Ivan, is they don't make this hole coronal enough. They do it kind of where I have it lined up, or they do it the apical portion. And like we talked about path least resistance, if I'm just going to run this one more time, just so I can show you another thing. If you take your next larger and larger drills, the palatal extent of this drill right here is the most palatal extent your implant's going to go, because your drills are going to drift buckle, okay, every time, because you're drilling on a slope, and B, you're drilling and there's a dense cortical plate here, and there's less density as we go buckle. So the most palatal that your burr is at the very, very beginning is the most palatal your implant will be. That's why it looks ridiculous to start way up here. But when you start here and your osteotomy is in this plane, that's where the back of your implant will be, and all the other drills are just going to widen it this way. Okay.
So that initial starting point basically limits or like sets how close you are going to be on the lingual side, right?
Correct. You're almost only going to go buckle from there, just because of the anatomy and just the way the drills work. There's a great video from a Bicon lecture on drilling on a slope that really like nailed this into my head for me. That was phenomenal learning. It's all about drilling on a slope, and how when you drill on a slope, your initial osteotomy is as much as you'll be on that slope, and you're just going to drift down the slope from there. I'll get you the link, and you can share that with your audience, because it's fantastic.
Okay.
All right, then you've got the guided osteotomy. So I don't know, most people that are doing guided are probably doing it on healed sites, as they should. And I used to make, since I had a 3D printer and scanners in my office, I could have a patient come in, hey, we're going to pull number whatever. Let me scan it. I'll digitally extract the tooth. I'll make a guide as if the tooth's not there. And then you have a guide for when the tooth comes out. So it doesn't even fit till the tooth's out, right? So that'd be like an immediate guide. You can do that in the anterior. The problem is it's going to line up that whole guide tube right over the middle of your implant. We just talked about what happens when you start your drill. You only go buckle from there, right? So if my drill, like in this case, if that's the angle I want my implant, and that's the center of my implant, hence that's where the guide sleeve is, and that's where the guided drill is, and I make my initial pilot the only thing that's going to happen is I'm going to go buckle from there. So you're going to do a guided immediate anterior, and you're going to look at the post-op. And you go, why is it so much more buckle than my plan? I don't understand. I do through the guide, right? And the guides have more slop than people think. I mean, we're putting 20 something millimeter drills through a small hole in the mouth. Like you just hold a guide next time you have one, put your drill in and wiggle the drill. You'd be amazed how much you can swing that apex in any direction. And so for that same reason, your drills can get deflected without you knowing. And you think I'm going through a guide, so it's perfect, and it's maybe not. So that's kind of the longer explanation of why I think guided immediates, especially into a slope, is a dangerous game to play. Because if you just start drilling really quick like you would on a healed number 19, you can suddenly have a restorative issue or maybe have a biology issue. So class 1 sockets, so great. We talked about this back a little bit earlier. Class 1 sockets are where the osteotomy should kind of mimic the socket. Cool. If you're going to do this, get a very, very brand new guided pilot drill, super sharp, full speed, and you're going to do a pecking motion. Okay. You're going to go until you just feel that plate. Barely pecking full speed because you want the least amount of deflection. And if you go like you are in a healed site in a flat ridge, your drill is going to just kind of slide down the plate. So actually, the animation for this is hilarious, but this is the animation for what a guided would be. So you're pecking, pecking, pecking. Once you break through, now you can go to depth. Okay, obviously my guided drill is very like hitting the palatal plate, but does that make sense? Like now that we've had a long discussion about guide, we did, because I think it explains why I don't like this solution.
It totally
Cool.
does, because I can see how as you're drilling, like that bone will push your drill to slide down that slope a little bit, and it's not going to go any more lingual than that.
Exactly. And all guides, your 2.0 drill is going to be guided right in the middle of your final implant. So ideally, your drills are widening from there. And what's really happening is they're just moving buckle. And so you're gonna have problems. And if you've had problems before, I know Sean was in the chat saying that he does a lot of guides. If you've had this before, maybe this just clicked a little light bulb in your head and you're like realizing why sometimes this happens. Because I think people are sold on guides just kind of being like the answer to everything. But that's why I think guides are really, really tough in the front. So I have 2 examples if we have time to go over them. It's the 2 we've already seen them. But this gentleman comes in with, obviously, I think number 9 might be our problem here. I'm guessing it's a little mobile. So he's got number 9. He's not a highly aesthetic demanding patient, but he's kind of annoyed that he can't chew things in his front teeth anymore without this tooth moving. So he comes in, gets full workup, CT and x-rays and whatnot. And in this case, we actually did do a minor envelope flap because we needed to see the extent of this buccal plate. He had a small defect on the mesial buccal that we'll get a better view of, but we actually were able to maintain that tiny, tiny bridge of bone, very thin, but we were able to maintain that little piece of buccal plate, which is key. So we're looking down the socket. We can see no fenestrations. We're looking at that thing we're looking at is the cribriform plate on the palatal wall of that socket. That's denser than you think it is, right? So we put our first pilot drill. It's coming out just lingual to the incisal edge, right? This is very restorable. We are in the palatal slope. This is a hard thing to get a photo of, so I apologize for brightening this up in post-processing. But now you can see that our osteotomy is in the palatal slope, right? We're not down the apex. The apex is buckled in this. So our osteotomy is completed. It looks like we probably went all the way to like a 3-2, and we're going to place, I think, a 4-2 in this case. So there's the 4-2 implant going in. You can see the buccal plate, where I'm placing it is at the right level. We have a defect just to the mesial. This is pretty questionable, Ivan. I'm not sure that I would recommend placement in a case like this if you're not really comfortable with grafting. But
Steven, can you say that just one more time, why you wouldn't recommend it?
I'm going to use my mouse cursor here. The defect we see here is a potential problem. We don't have bone. If we are losing this interproximal bone, you'll see this at the end result. We're not going to have good papilla height here, okay? Because we don't have this peak that we have over here. So the peak we have here, this is when I was talking about the 4 to 5 millimeters. From this peak to the contact point here, 4 to 5 millimeters, you'll get a papilla fill every time. Okay. So what that means for a lot of patients is their anterior implants end up being kind of long, boxy looking teeth because we have to move the contact point so apical, because these aren't natural teeth. So, but maintaining this peak of bone is so important. And if you lose this, It's just going to be a soft tissue problem down the road. Now, he already lost it, and he didn't have it much to begin with. If you go back to his initial, like his papilla was already kind of flat, and obviously there's quite a gap here, clearly. And he's not a big, highly aesthetic demanding patient. His smile line's not even that high. So we can kind of get away with it here. But if this is your young 30-something-year-old patient who has a high smile, this is something where soft tissue is going to really determine how successful you are, not so much the bone. So that's the defect I'm talking about, though. So now, looking back, I mean, I think you could make a call either way. If you're very comfortable with grafting, great. It's not a bad idea to maybe graft and try to rebuild this bridge of bone here, let everything heal and come back in place later. But I would expect some gingival recession here regardless. So the implant's placed. You can see where if I had a perioprobe laid from CEJ to CEJ, we're about 3 to 4 millimeters apical, which is where we want to be for our emergence profile to allow us. And we're right. This angle is kind of misleading, but we are below the buccal plate height here by about 1 millimeter. We're kind of leaning and looking down the socket a touch. Okay, so got good stability. Implants in. We're going to graft everything. This is a cortical cancellous mix. The cover screw is on there just for the graft, okay? Because I just don't want graft to go into my implant.
Hey, Steven, just real quick on the mesial, you didn't have a wall, right? There's no socket.
There's a small dehiscence here. It's not all the way apical, but I think it's about 2 or 3 millimeter dehiscence. So correct, yeah. So we're gonna need a membrane of some sort, right? So right now we have this is cortical cancellous. I put the cover screw on when I'm doing the graft around the gap because I don't want graft down in the implant body, right? So wouldn't it be funny if I just closed this up and said, there you go, when I just complained about cover screws that needed implants? What I'll do after this, and I'll kind of remove the excess because I don't expect to get much height of bone here, so I'll remove this excess, is I'll take the cover screw out then and then put the healing abutment in. So 5 millimeter tall healing abutment, that is a pericardial membrane, which is an allograft membrane. That means it's human tissue. It's just a donor tissue. Are you familiar with pericardium? You use that much, Ivan?
I haven't used it.
I'm a big fanboy of pericardium. I use it. You'll see it in a lot of the cases I post on Instagram. I love its handling. It's kind of expensive, but it is very resilient. It's resorbable. So it's basically a marriage between PTFE and like collagen, where it's resorbable, but it has a little bit more resiliency. So in a socket preservation case, I'm comfortable putting pericardium and having it exposed a couple millimeters, 2-3 millimeters, because it's resilient enough. It won't, unlike a memlock, like a collagen, it won't just like swell and fall out. And you can tack this. I don't tack it in this case, but you can tack pericardium because if you remember in like D1 year, pericarditis or the swelling around the heart kills somebody because the pericardium does not burst, right? It's so tense and resilient that the swelling around the heart actually chokes the heart rather than this biomaterial breaking. So you can cut it with scissors very easily, but you cannot tear this. And what I've noticed when I'm trying to tack a resorbable membrane, if I'm tacking a memlock or, for example, collagen, like a bovine collagen, it tears really simple. So I'll tack it in and then like accidentally grab it and it just slips out. And I'm like, oh man, like don't have that problem with pericardium, but I'm also not tacking a titanium reinforced PTFE that I gotta get, in a couple of months. So it's expensive. I think it's like $80 for a piece this big. But it's resilient. It has a couple of different advantages. So I really, really like it. Just for the resiliency and the resorbability. So anyhow, in this case, I'm doing a poncho technique. So I literally used a sterile rubber dam punch and punched a hole through the bottom third, the middle of this, and I'm feeding my healing abutment through the hole. Okay. So now the healing abutment gets seated fully. Make sure you hold on to that membrane or have your assistant hold on to it so it doesn't twist right at the end when you're seating the healing abutment. Then that membrane is going to get tucked down the buccal to kind of repair that dehiscence that we saw earlier and maintain our graft.
Question.
Yeah.
If you are going to be tacking it down with the healing abutment and you make sure that it's not all twisted up and it lays down nicely inside your flap, do you have to tack down the membrane or you're comfortable with the healing abutment doing that for you?
I'm comfortable with the healing abutment and some sutures to hold this thing down. But if I'm doing like a GBR with this, there's 2 techniques. You can either tack or you can do those periosteal sling sutures. And whatever's comfortable in your hands, this material can handle it all. I think BioGuide, which is a porcine collagen, it's like that really stretchy stuff. It also tacks very, very well, and I've seen a lot of people have success with that. I love pericardium. It's just the handling. Like when collagen gets bloody, it's a wet noodle, right? When this
Mhm.
gets bloody, it's a slightly less wet noodle. It still has a little bit of
Uh-huh.
like stability, right? So that's why I like this material. And keep in mind, my job, everything's, the biologics are donated, so I don't have to pay for this. So in a private practice model where this is $80 a piece, yeah, I guess that could get. So just fair warning, is a little more expensive, but the handling is fantastic. Suturing, those are PGCL sutures, which is a long-term resorbable suture. Um, it's similar to PGA or Vicryl. I'm a big fan of it because it's monofilament. This is a great picture to show that's monofilament. It's not braided. So it's really, really good at not having like bacteria stick to it. It slides really nice when you're doing your knots. This is
Can you say
the,
that one more time? Like, can you say that the name of the suture again one more
yeah,
time?
it's called PGCL, which I think is
Okay.
like polyglycol something, something. I don't know what the chemical name is for it, but it's similar to a PGA. It's about 4 to 6 weeks resorption. Monofilament though, so it's not braided, so it slides a little bit nicer. I consider this like if PTFE sutures and chromic gut sutures had a baby, it would be this suture material right here.
Mhm.
I use it all the time when I'm doing stuff in the vestibule that I don't necessarily want to have to go try to cut out later. So big fan of PTFE sutures, but I don't use them for mattresses. I don't use them for anything subperiosteal. I'll use this because it ties just as nice and sticks around quite a bit longer than chromic. Okay. So it looks like we did probably a mattress is my guess. It's kind of hard to see in this picture. And I honestly can't remember. It looks like a couple interrupted as well, to kind of put everything back together. So this is the post-op CT. You guys saw this one earlier. We did perforate the buccal a little bit. That's a 15 millimeter implant. So the bottom maybe millimeter, which we didn't tunnel enough to see this, but I felt it, with my finger, and there was no external sensation there. I couldn't feel the body of the implant. It torqued out really nice, of course. So now got a little extra torque there using that buccal plate. It's very restorable. I'm just going to leave this. Look how thick the buccal plate gap is on the coronal portion. I don't expect this to ever be a problem because we didn't flap up there. So we didn't expose this to the oral environment. People have different opinions on that. If it's, like I said earlier, if it's really perforating, like the body of the implant is out or it's stripped or you can feel it, then it needs to be removed and repaired. This is the patient's final. Unfortunately, I don't have any of his uncovery or like impression pictures, but you can see we did get a little bit of that papilla fill, and he opted to go with no diastema. So this
Mhm.
tooth is a little bit wider than this one because you remember his previous photo, he had a very large diastema, right? And this is the Ivan. How many patients you're doing the shade, and they go, "Well, I'm planning on bleaching."
Okay,
That's
all
this guy's still planning on bleaching a year later. I don't know when it's going to happen, but number 9 is a really nice white color, only like one shade brighter than everything else, but he swears he's going to bleach. So looking forward to
fantastic.
that.
This
But
is
yeah,
a
it looks really good. And this is day of delivery, so I'm not sure if this papilla hopefully will fill in a little bit more. I'm not convinced we'll ever get this to be completely full, but it wasn't before. You can see we have a nice, this is a straight, there's no angle screw channel on this. We're just barely engaging or cutting through the incisal edge. So that's the access point. Looks really nice. Obviously, no occlusion, no excursives on the tip there. And the before and after. It's kind of amazing that this doesn't look super, super wide, but what you can appreciate is how much buckle that number 9 had displaced before. So, no, really good result, even with the buccal plate dehiscence, even with all the grafting, the membranes, and everything else. So I was really happy with that.
that looks
And
good.
what questions do you have about that case? We got one more to do after this.
Let's see, somebody's got a question right here. Sean, do you have your patients come or go for regular oral hygiene visits? Well, I guess it's just like your regular implant follow-up, right?
Yeah, they should, you should have your patients back a couple days later to a week later to double check your occlusion and make sure that they're functioning as well with it, and it's not a bad idea. Then a normal recall, whatever they're doing for their hygiene recall, but you should get a PA of your implant at least once a year to track bone levels, and it should be a really nice parallel or perpendicular PA, like so you can see the threads and the bone level. Um, but yeah, they should be coming here just for regular, and your hygienists need to know how to clean around implants. So if you're placing a lot of implants and your hygiene team is kind of not comfortable with the techniques, then that's something you'd want to send them off to learn.
For sure. Yeah, 100%. No, let's look at the next case, man.
All right, next case. This is that one you were talking about with the jig. So I'm excited to show this one because this one is really, I think, quite cool. So patient's name is Marion. He comes in, funny guy. He lives in North Scottsdale, and he comes in with like this. He had been gluing this tooth back in for a couple weeks at this point. So it's amazing. He said it would even stay on for, a couple of days, which kind of blew my mind. But so he comes in like this, and number 7 is missing. Here it is from the occlusal, and he has these nice crowns, from 5 to looks like to 14 that all match. So we're talking about immediate temp. He doesn't want to go without a tooth, yada yada yada. Well, no bisacryl that I can make is going to match this ceramic, right? So we had that tooth. I put it on. It kind of locked in. We knew we were in the right spot. And this is simply I put Vaseline on number 6 and 8, and we put a little bit of bond on the incisal of 7. And this is just composite, just bulk composite, whatever you want to call it, packable composite. So just to have a little seating jig. So now that composite is kind of bonded to number 7, and we're going to come back to this later. So tooth roots removed, flapless in this case. And we go and we get our 4.2 by 12 or 15. Certainly a 3.8, which is the BioHorizon size implant, would work just fine for a lateral. But we went up with the 4.2, and you can see really nice placement. We got a nice gap. The gap there looks about 2-3 millimeters. So we're going to graft that gap because we can. And this is an ISQ peg, so we're checking the initial stability. And the ISQ was well above 70, so we're more than happy to put some sort of immediate temp on this implant. And then we're going back. So then after this, I drilled out the tooth that was inside the crown, and we drilled a hole through the lingual and the cingulum, and it just lined up really nice. What you're seeing is a peak temporary cylinder on the implant. So we drilled it out enough to get that to fit passively over, just use some bulk flowable to kind of pick it up, cure it. And then that comes back out of the mouth like the picture on the left. And that margin that you can see here is where we need our material to go to. So we take it to the lab, we're doing chair side, we're just adding more flowable, polishing this really nice, and getting it down to that margin. And then this goes back in the mouth. And
Steve,
notice, yeah.
so that was just a peak temporary abutment, just like a little chimney.
Yep.
And you hollowed out the inside of that tooth enough to fit passively through that.
Exactly. And the doctors who placed it so perfectly. It's just, you really can't do any better than that as far as where it's coming out. So that just had to cut his tooth root out of the tooth, right? It's a ceramic crown, and then just cut through the ceramic on the lingual to get access to that. And then one thing you'll notice here is there's no contact between 7 and 8. And the reason for no contact here, I've been asked this before. It's everyone knows not to put contact on the incisal edge of an immediate tooth, right? Because you can't have any off-axis loading angles. And this was buffed out later. But people forget about fremitus and people who have really, really tight bites. And this guy was a bit of a grinder. So if you were to put your fingers above the buccal plate and had him bite down and kind of squeeze, 8 moved a little bit. And if you have a really tight contact with your implant immediate and he squeezes, even though he's not touching this one, and 8 moves, he's going to be putting some sort of lateral weird force on your implant. So probably didn't have to open it up this much, but we just used a disc kind of at the end. But making sure that your floss slides through with no point contact, right? No dense contact. It's something that I've never really heard anyone else talk about in lecture when they're talking about immediate conversions. But yeah, make sure you're not getting a lot of tight contact, especially in someone who has grinding issues. All right, so here it is from the facial. So we're able, these papilla will grow back. We're sure of it because we did a little bit of damage just pulling the tooth out. And you can see we cut it a little bit high just so it's not an occlusion. Mm-hmm. And here he was at 2 weeks. Everything's feeling good. And then this was his final. So we got the length back, make everything kind of match as much as we could with the dreaded single incisor ceramic. Everything looks great around the implant. It looks like he has some problems around his natural teeth, some gingivitis, but the implant looks good. So that's his smile line, though. So we've got even more room to play with, and this is the final restoration. So that's it, my man.
It's fantastic. I love that outcome on that case.
Yeah.
Thanks so much for sharing that, man. I do have a couple questions for you. Sean said You did a great job too. um, well, awesome, man. Thanks so much for sharing. But these all these gems for immediate placement. I feel like I can go do it now.
Awesome, awesome.
Steve, I do got a question though. So, all right. So, BioHorizons is internal hex. One of the biggest, or one of the most common pieces of feedback that I get on our implant system that's coming out is, oh, I read zero bone loss concepts. I can't use internal hex.
Mm-hmm.
I guess you placed so many of these already, internal hex.
Yeah.
What practical difference do you see between conical connection and internal hex as far as the micro leakage being like damaging your restorations or your implants?
Yeah, this is a conversation I have a lot since that book came out, and Thomas has a ton of BioHorizons implants in that book, and his Instagram feed is full of ones that are good examples of when it works. And when I first read that book, I had the same concern. I was like, oh, I guess everything has to be deep conical, but it's the more you read into it, realize that's really not the takeaway. The takeaway is knowing the connection of implant you have. You just have to know where that implant will succeed. And it really comes down to tissue thickness above your connection. One thing that internal hex might not be as good at is being super subcrestal. So if you know that you have a thin tissue and you want to go subcrestal, then maybe you should consider soft tissue grafting to thicken up your tissue, or doing some sort of countersinking. So you sink the implant 2 millimeters, profile the bone, and do like Thomas even has a technique in his book where you tent it on like a 3 millimeter healing abutment and tie the tissue there and let the tissue fill in. Because it really comes down to like biological width of implants around the connection. Where conical succeeds is in places where you need to place it 2 or 3 millimeters below the bone, and you have like an immediate, like all on X, for example, it has some good examples. Or that your tissue is so thin, I'm just going to place it deeper for that reason. So there's a lot of examples of internal hex has probably been around the longest. It probably has the most implants in patients' mouths in like the world. And I think a lot of people read that book and thought like internal hex was canceled, or like suddenly all the internal hex implants were going to fail or fall out or something like that. That's clearly not the case. It's just knowing where it's appropriate. So internal hex in the healed site should be like at the crest or just below. You don't want to be sinking them like 2 millimeters subcrestal just because. And if you have a tissue thickness issue, you need to, fix that prior to loading that implant. That's kind of been my experience.
Mm-hmm. Awesome, thanks, man.
Mm-hmm.
Good. Let's go ahead and end this. I record the whole thing. I'd love to hop on a quick Instagram chat with you, just one-on-one, just to catch up with you real quick. Is that okay?
Let me check in my 8-week-old baby, and then
take care of your baby, man.
Yeah,
Let's just stay in touch.
Yeah, we'll see. We'll do it some other time for sure.
Hey, I appreciate you so much doing this, man. I think we were only scheduled for like 30 minutes. I think you went for like almost an hour and a half with like so much content. I appreciate you, man.
All right, buddy. It's good catching up, man. Take care.
All right. See you, man.